including this panel discussion on sessions. Thank you very much. And to start with, I would love to place that today we are going to spend time on discussion on ventral hernia repair, and I am surrounded by the stalwarts. And all of us know that Dr. Pramod Shinde from Nasik, Dr. Jignesh Gandhi from Mumbai, Dr. Sarfaraz Baig from Kolkata, Dr. Baiju from Trivandrum. So all of us will be discussing about the ventral hernia repair. And in this next 1 hour, I will be bombarding them with the absolute straight, blunt, embarrassing questions, and they will simplify it to the maximum so that all the surgeons, especially keeping in mind the postgraduates and the practicing surgeons, they will be benefited from this discussion. Dr. Shinde, Dr. Jignesh, Dr. Sarfaraz, Dr. Ramesh Punjani, all have been doing the laparoscopic way, open way. Then they have gone into abdominal wall reconstruction. So my questions will be absolutely basic so that I would pretend that I do not know anything about ventral hernia repair, and these are the stalwarts who are going to give you the answers so that our practical approach to the patients will improve. Thank you very much. I honestly have requested my panelists not to go much into the data, but definitely make us wise by their pearls of wisdom. We welcome Baiju Senadhipan also, who is doing an excellent job of conducting webinar on every Sunday, thanks to Corona. Thank you very much. Now, let us start with Dr. Jignesh. Dr. Jignesh, I am going to ask you that when the patient of ventral hernia repair comes to you, then you get the investigations, and do you want that each and every ventral hernia, query / incisional hernia should have the CT scan?
Jignesh seems to be frozen, maybe because of the internet.
Yeah, so Dr. Sarfaraz, I would just pass on this question to you, that do you want that any and every ventral hernia patient should have the CT scan or not?
Well, earlier we used to use CT scans sparingly. Recent understanding of incisional hernia especially has made us aware that in this particular setting, CT may be very helpful, especially in the obese patient. A, we can pick up the multiple defects. B, we can look at the condition of the muscles. C, we can know about the intra-abdominal mapping. Some patients are post-cancer, some patients are post-laparotomy for infections. So we can know the residual disease of the primary surgery. Because of these important information, a CT scan for incisional hernia has become important, whereas for a primary ventral hernia, it may not be that important. So having said that, yes, CT scan is more and more used. It is more like a map. It is more like a baseline. Some people even would use it for prognosis years later or months later for knowing whether the treatment has been satisfactory or not. So the answer to your question is yes, to a large extent, is being increasingly used in incisional hernias.
Wonderful. Dr. Jignesh Gandhi, you are with us.
Yeah, can you hear me, sir?
Yeah.
Can you hear me now?
Yeah, sure. So I would just
for the primary.
No.
Yes, sir.
You will have to wait for my question. Now, next question would be that given the choice, you would go in for CECT, NCCT, or MRI. What is the investigation you would love to have in these kind of patients?
Yeah, so for contrast enhanced CT scan is always helpful because it tells you about the tenacity, the way if the patient has undergone any previous repair. And if I'm looking at an infected scenario, I'm talking about, say, class 3 or class 4 hernia with a recurrence, where I'm suspecting some infected fluid, then MRI would score better than a CT scan because it is good to detect the fluids.
And you would go in for primary hernias also?
No, primary hernias, no CT scan, a non-invasive investigation like ultrasound. But if I'm suspecting that the patient has developed hernia of a recent onset, then there are sometimes I've seen that there could be something intra-abdominal.
I would not go for an MRI unless, as Jignesh said, that there is something which we can't really see on a CT scan. In a complex incisional hernia with an infected mesh and infected scenario, even in that situation, my first choice would be a CT scan abdomen. So I would take it as a baseline investigation. And then after having seen that CT scan, if the patient's management mandates that I need to look at where is the collection, a little more details, then I would definitely go for the other area where I am suspecting that there could be a retained lipoma, then an MRI will really help me. But in a ventral hernia, I would always use it as a second modality in a very specific situation.
Dr. Ramesh Punjani, when the patient of primary hernia comes to you, do you think that IPOM is dead?
No, not at all. I still do it, and I think it is going to be there all the time.
You would say that even in ventral hernias with incisional hernias, for example, the IPOM is still the choice, or would you go in for AWR?
No, so it all depends on the defect size rather than the. So incisional hernias, yes. In fact, with the laparoscopy, you can do a thorough adhesiolysis and a safe adhesiolysis as compared to ETAP. And if the defect is less than 4 centimeter, I would certainly consider IPOM. But I'll put a very big mesh covering the entire scar.
For you, the limit of IPOM will be that the defect size is
4 centimeter, and that also I would close it.
so that will be the limit for IPOM plus.
Yes, IPOM plus.
There will be any situations in which you will not do the IPOM plus, but you will do the IPOM.
No, I would never do that.
Dr. Baiju, what shall be your size in which you will definitely think that this kind of 8 centimeters defect I can tackle with IPOM or IPOM plus, and beyond 10 centimeter or 13 centimeter or 15 centimeter, I will never go in for IPOM. So what is the cutoff mark for you?
So, first of all, I would like to thank you for again the opportunity, and also for the nice words you put in regarding the Senadhipan Education Foundation. Now, regarding the question whether any cutoff is there for the IPM or not, actually there is no cutoff for IPM. It's all depending on the abdominal wall texture. Means the abdominal wall is lax and it's approximatable. I will do an approximation and IPM plus, and also loss of domain. Loss of domain, I will not go for an IPM plus, but definitely go for a AWR only. Any sort of component separation. But the thing is that there is no cutoff value for this patient will go for IPOM plus, or the other patient will go for AWR. It all depends on the patient texture or abdominal wall laxity at all.
Dr. Jignesh, you want to chip in, please.
So if you want to give the number, I would say up to 5 centimeters IPOM or IPOM plus. Between 6 to 8 centimeters is a gray zone. However, there's a very
cirrhosis without diabetes, right? So patient factors are of paramount importance. Hernia factors cannot be only limited to the width. It has to do with the area. It has to do with loss of domain. So hernia width itself does not tell us the entire aspect of the hernia. Similarly, this EHS does not capture about the wound. A patient with an infected mesh and a sinus tract is definitely different from another patient, right? And lastly, what about recurrences? How many times the patient has failed a surgery? So EHS classification is the present classification. However, it does not tell us everything. It doesn't capture everything. Therefore, we need to modify classifications. And I think the hernia factors, patient factors, wound factors is a much better way of communicating. And as probably most of us know that at our center, whenever any surgeon comes, we always coach them to talk in this particular manner when describing a hernia.
Good, excellent. Dr. Ramesh Punjani, do you think that there in your jargon of so many hernia surgery, you are the master of hernia and you have been doing this. So there are any contraindications of doing IPOM or IPOM plus?
So whenever I would not close the defect for whatever reason, I'm not going to do an IPOM. I'm definitely, I don't want my mesh to event rate or a hernia to recur, because wherever you have not done the recurrence, the seromas, everything increases. So therefore, whenever I can't close the defect, I'm going to subject it to a component separation, whether open laparoscopic, that depends on the size of the width. One thing that Sarfaraz said I would add is that, so therefore Petro has given a classification where he has taken only two factors. The one is width and second is infection. I think that is a more practical classification than any of these other classifications, which are only talking about the location of hernia. The location is not as important as all these two factors. So I think that's what I wanted to add.
Dr. Baiju, do you think that, for example, if a patient of cirrhosis with ascites, with umbilical hernia, large umbilical hernia comes to us, what are you going to offer to him?
Actually, in that cases, probably I will be avoiding an IPOM because the patient will be having ascites and the chance of secondary bacterial peritonitis is there. So most of the time I'll be avoiding, but if the patient is having cirrhosis without ascites and it's compensated and there is no chance that ascites can happen, probably I'll go for IPOM. Other cases I'll do open online mesh only.
Dr. Shinde, have you burnt your fingers after tackling such kind of situations in which the patient had the decompensation afterwards, after IPOM or IPOM plus and cirrhosis with portal hypertension with ascites? Have you ever burnt your fingers?
Yes, I have. And IPOM plus is also one of the techniques used in liver cirrhotics, but then I have burnt my fingers when the patient becomes decompensated, and then we have to be prepared to deal with it with the help of a medical gastroenterologist. Then he requires everything possible, right from paracentesis to the albumin replacement and whatever. Occasional patient might go right up till tips also. So because these patients are on the borderline, although we take care of ascertaining that they would be fairly fit for patients, sometimes the patients comes with a leaking hernia again. And in that case, we are left with no alternative but to optimize them and take them out. But even for a possible patient who looks okay, can decompensate in the postoperative period, and we always take consent from the patients, and we are ready with the help, and we are ready to take it on in case if the patient decompensates. But if it decompensates, it's quite a hell, and then patient can go either way.
Dr. Jignesh.
Sir, ascites, liver problems, elective setting, ascites, liver problem, patient coming in emergency. If it's an elective setting where the patient comes to you, try to convert them from child C to B or B to A with the help of your hepatologist, and then plan it. Definitely play an open surgery for me. And now there are papers which are mentioning about use of 2 mesh because it acts like a sieve so that it doesn't prevent the leak of the ascites from the site of the hernia. And nowadays also we have also included of giving ICG in this patient so that you can see the collateral, see the vascularity and close that well. It works very well. Patient coming in an emergency setting, you have no option but open surgery. A good idea is to leave in a drain, give albumin to the patient, there is a drug called Gutron, which a lot of my hepatologists in the transplant center, because I'm at the place where
many times in last 30 odd years you have been practicing hernia? And 20, you are still young, right?
Yes.
How many times have you explanted the mesh?
So,
Especially in context with IPOM and IPOM plus. We'll come to AWR later on, but especially in context to IPOM and IPOM plus, how many times you have explanted the mesh?
So I have to actually disappoint you. I have not explanted a single IPOM mesh of my own practice, and I have explanted 4 of patients referred from other centers. So that's in 20 years. But I have explanted groin mesh at least another 4 times. So 4 plus 4, 8 times. And in groin, I have explanted 2 of my mesh. But in IPOM, I have never explanted a single mesh of my own. I have not encountered PTFE because by the time we came into practice, the PTFE meshes were going away, and we had to use meshes by ASICON and Medtronics like Proceed and Paritex. So we have been acquainted with these meshes, and I've never faced that. But the ones which I have removed, yes, I've seen infection can get really bad. Adhesions can be really bad. Explanting can be a terrifying experience. But that's what you asked me, so I'll just restrict myself to that question.
So maybe I am slightly older than you. I have explanted a good number of meshes, and I have explanted EPTFE meshes, the Proceed meshes, also Proline meshes also, and definitely EPTFE has gone into disrepute just because once the infection was there, once it was a microporous pus, microporous mesh, it would not, and ultimately one has to take out the mesh. And a lot of such situations have been there when the discharging sinus was persisting on the abdominal wall. Even if, for example, enterotomy had been done, people did not remove the mesh at that sitting. And later on, the persistence of the discharging sinus continued, and we had to explant the mesh. Dr. Punjani, in your practice, how many times have you explanted the mesh? Or do you think that we are unnecessarily blaming the mesh?
No, I think whenever the mesh infection happens, it is because of the surgeon and his setup. That is for sure. I don't think we can blame any mesh. Yes, but certain meshes have a more sort of a tendency. If the infection happens, they have to come out. So even if I use a PTFE mesh and if I don't introduce a bug inside, it's not going to get infected. So the point is that another thing, no, some patients have already a hidden infection like MRSA. And very recently, I had one very nasty patient where, in fact, I did an IPOM, a very fat lady. I never knew that, you know, that she had, of course, multiple surgeries, but last surgery was 3-4 years back. And so I went ahead and I did an IPOM for about 7 centimeter recurrent hernia. I could close that very well because of flabby abdomen. But this mesh got infected. And then I realized that that pus that was cultivated, that was the MRSA. And therefore, I think now we have to be very careful, especially people who have multiple surgeries, multiple admissions in hospital. They could be carriers of MRSA. And thereafter, you know, what I've started doing a practice, all these patients, while they are waiting for surgery, ask them to put a mupirocin in their nostrils, you know, in case they are MRSA carriers. So that is something which has frightened me off late. In last few months, I had one infection.
Right. Baiju, I would ask you a practical question, but you should give me the answer from literature support also, that you are doing an IPOM plus and you have done an enterotomy, inadvertent enterotomy. So you would go in for placement of the mesh or you will withdraw yourself?
Yeah, it all depends on the quantity of injury you have made and the place of injury. Probably in a case with a small nick on the serosa with a suspicion of mucosal exposure, probably I will close the defect and do an IPOM plus. But if it's a larger injury with the pouring of bile and the intestinal contents, I will not go for it. Second thing is, if it's a colonic injury, definitely I will avoid a IPM plus. And actually, the literature is against placing a mesh if any endotomy is there.
Sure, good. Dr. Shinde, you have been doing hernia repairs since maybe 92, 93 onwards. What made you change your thoughts about AWR? What I mean to say that you have been comfortable with IPOM, IPOM plus, and then you switched over to AWR, and now you are managing AWR so well. What made you change your thoughts, and what do you want that our younger colleagues should learn, that they should learn all IPOM, IPOM plus, AWR techniques, and then progress? So please go ahead.
Well, the IPOM definitely brought in the era of a bridging repair. But since we were surgeons, we started closing the defects early. But it was not really an abdominal wall reconstruction. And especially some centers, in fact, in India, we had Dr. Palanivelu's group closing the defects very, very early. Okay. And component separation came into our practice around 2010, but that was an open component separation. It was used very sparingly, and it was used only for very large hernias which could not be operated with just an onlay repair or a sublay repair. Reefstopper was in my practice at that time. But the real scenario of abdominal wall reconstruction changes came around 2014 and 2015. When on an international level, there was a lot of interest in component separation, endoscopic component separation. And by then, Yuri Novitsky's TAR came, the paper was published. And in some of the international conferences, we heard them talking about it. So 2014 was really the watershed area for me when I got introduced to the endoscopic part of the component separation. And after 2015, there was no looking back.
No, my question was, you have been successfully doing IPOM and IPOM plus.
Yes.
You are not giving a lot of recurrences, but
Yes.
still you thought that there are situations, there are patients who need more than this. And that changed your practice, or you thought that you have been doing a wrong operation for last so many years, and now you need to switch over to the next generation of operations and then ultimately give the benefit to the patient?
No, the patients do teach us. Our own patients do teach us, because as we become senior, we get more complicated patients, we get obese patients, we put larger meshes, and these patients started coming back with bulging, with recurrences at the edge of the mesh. And we have already done using a larger IPOM plus mesh and IPOM plus with a larger mesh. And still, when these patients came up with, one factor was the postoperative pain, the other factor was recurrence, the third factor was bulging. So in that scenario, it became obvious to us that IPOM plus does not satisfy the larger hernias. The smaller hernias were all happy. They wanted the endoscopy. But when these larger hernias started coming to us, that those patients teach us that we are going somewhere wrong. That's when we start looking for answers. And luckily, answers are available, but we don't look for them. Most of the times, it's our own patients and our community and our conferences which make us look for those answers. Especially conferences and workshops also enlighten our mind in that. So patients and conferences. These are the two factors which make us change our mind.
Dr. Sarfaraz, again a blunt question, embarrassing question. That do you think that those surgeons who are putting in mesh inside the peritoneal cavity, they are criminals?
That's not an embarrassing question. That's an illegal question. You should be not allowed to.
No, what I mean to say, in last few years, as Dr. Shinde
I get you.
mentioned, 2014 onwards, all of us have started thinking that we were doing some criminal by placing the mesh within the peritoneal cavity, and now new thing has come, so we should ride that wagon.
So I'll just give some random thoughts on this.
Dr. Santosh John Abraham has also switched on his video. Welcome, sir.
That was because of your question.
I was
Yeah.
amused by Sarfaraz's answer. That's the reason I thought smiling on my face.
Oh, well, as soon as he heard about there's a crime going to be committed, he came in the picture. Okay.
Watchdog.
So,
Yeah.
watchdog, yeah.
Yes.
So, very frankly, I think the reason why you asked this question is because the way things, when they change and it is being put in the newscast, social media, in conferences, that is the reason why people tend to ask these kind of questions. Well, nothing wrong with that, whether it's bariatrics, whether it is liver surgeries going from resections to transplants for cancers, whether it is from in anal fistula where people have gone from fistulotomy to valve to lift and then coming back to fistulectomy, sphincter reconstruction. Things evolve. And people who actually promote one particular kind of procedure over another tend to get a little more less than cozy, more aggressive, more flamboyant in their expressions. And when these come up on the social media, or when these come up in the conference, when they come up in any conversation, one tends to feel that the old thing has gone away, which is not true. You and I are pretty mature, and all of us on this, in fact, platform are very mature to see things evolve in science. They go a full circle, sometimes they come back. So Reeve-Stopper has gone from 70s and come back after 2010. What does it mean? Does it mean we are getting older, or are we going back to the primitive surgery? No, it means that our understanding is maturing about a particular surgery. IPOM is here, has done well for lakhs of patients, if not more, and it has served so many patients with a recurrence rate according to, I remember this Chalalas paper that Jignesh is talking about, 1,300 patients with a recurrence of less than 3%. What else can somebody show? The procedures have always been good. It is the man behind the machine which has been very important. Some people can run a robot very well. Some people can run the straight sticks of laparoscopic very well. Some people can do open surgery very well. As long as their failure rates are low, how does it matter what you or I do? So very philosophically speaking, I'm so sorry about being philosophical in a forum which is scientific, but you know, I have a poet and a warrior inside me. So I'm being poetic. The answer to that question is the reason why you were asking is that at times people tend to promote the newer things in a way as if the old things are gone. It's not true. The old things are there. It is improving our understanding. The new things are all right. They are coming in for situations where we could not manage from old things. So, long sentence short, long question answer short is IPOM in my hands is still 80% or 70% of my practice. 20 to 30% of my practice has changed in large hernias, loss of domain hernias, in hernias which are in atypical locations. Yes, I have changed my practice there.
Wonderful. I would say that every gun is safe. Man behind the gun has to be safe. Right. Dr. Jignesh, I think we'll dwell for a few minutes on IPOM and IPOM Plus, and then we switch on to AWR.
Okay.
Do you want that any patient who has ventral hernia and gallstones, so would you do in for laparoscopic IPOM Plus or appendix or hysterectomy? So do you want some associations to go on, or they should be dissociated?
Okay, so I will answer it in two parts. One is the scientific way and one is the non-scientific way, or the way the people practice in day-to-day practice. So first, coming to the day-to-day practice is sitting across with the patient and telling him that yes, this both can be done at the same time, but your mesh will be in a different plane, but that will add another number of hours to the procedure, economics of the patient, longer stay in the hospital. So yes, I would like to combine a laparoscopic cholecystectomy with an open umbilical hernia repair, putting in a mesh in a different plane. This is what I would like to do if I'm sitting in front of the patient. Scientific answer to that, if I'm combining both and if I'm putting in the mesh in the same plane, because there has been a literature where you bag the gallbladder, minimum spillage and do it, about 1/3 of these patients can land up with significant surgical site occurrences. So if the patient is ready to take that 1/3% chance, sitting across, giving you the consent, then you will opt for it. But if you ask me what I do for every of my patients, it's what I'll do for my relatives. So I have two answers to that. One is, which I've given, is a scientific approach, and one is a non-scientific approach. So appendicitis, definitely I would not like to combine, because the bacteroids in the appendix is the one which is a notorious organism. Even if it comes in your skin or subcutaneous, you can have a weeping wound for weeks together, which is, confuses sometimes with an atypical. So appendicitis, no. Hysterectomy, a lot of times the gynecologists have called me in that, sir, we are going to do a hysterectomy. Can you combine with an umbilical hernia? Again, the same answer, combination. End of the hysterectomy, I'll do an open repair, do a preperitoneal repair, but put the mesh in a different plane. Having explained to the patient, 1/3% chance, if the patient is a low risk, if the patient is a high risk, that means associated diabetes, uremia, CKD, or immunocompromised patient, then the chance stands higher than a staged repair. So the take-home message for the residents and everyone, always try to do a staged repair. That is a scientific approach. But the real-time approach, what we see in clinical practice, is sometimes because of the health economics, we have to do a combined procedure, again bringing in the scientific principle together.
Wonderful. Any of you would disagree with Jignesh that you would combine the procedure? You, Dr. Punjani, you will combine the procedure?
No, I will not. I will not. So I will not do it. In fact, with 30% to me is a very big chance that the patient is taking.
Yeah.
So it's better not done.
It is better not to combine cholecystectomy and ventral hernia, umbilical hernia repair. If you have to do it, then do cholecystectomy first and maybe ventral hernia repair, mesh repair later on. Or you just place in a suture and tell the patient that you are going to have some recurrence later on, because that is not the final answer. So you, at that time, if you develop the hernia, you will have to go in for laparoscopic IPOM or IPOM plus. Dr. Ramesh, now switching over to AWR, next 25 minutes on AWR. Why did you go in for component separation? And please, for the benefit of me, one, and for all the benefit of all the younger PGs, what do you exactly mean by component separation? Means, please simplify it to the extent that even fool like me can understand.
No, you have understood it, but I would put it this way. What has happened is that when the IPOM came, we all went overboard. So what happened, I remember that I was asked to do on live surgery as a demonstration in a workshop, and I myself put in a big mesh of 10 centimeter big defect. Same patient in 3 months came back to me with a recurrence. He found out, I sent it to one of the very big surgeon of Bombay, and he said, usko homeopathy treatment chalu karo. So this is how, in fact, we were trying to, sort of stay away from patient, but that does not, the patient's quality of life is so bad. And in those days, I came across Paradavila, who first time ever in Lilavati Hospital in Bombay, he demonstrated a anterior component separation. Now that made me interested. And then I started taking a keen interest. I went a couple of times even abroad, learned initially anterior component and then even the posterior component separation. And I think that it is definitely required. But then again, nothing is bad. I mean, the IPOM is not bad. It has to be done, as Sarfaraz said, even I do a large amount of my patients. But big hernias, anything about which I said what I cannot close, I would probably definitely do a component separation. Now, to put a component separation in a simpler manner, it is like that, it is like taking from one person. It's like Robin Hood. You take it from one, give it to other. Now, when you can't close a midline, the God has given us 3 muscles which are there, which are available. And I always give the simile of a stepney. We have 5 tires in a car, but we use only 4. The 5th one is there for us to use it when in emergency, when one tire is not working. Now here you can't close a midline. So you sacrifice one of those obliques. So if you sacrifice external oblique, it becomes anterior component separation. If you sacrifice transversus abdominis, it becomes a posterior component separation. So you sacrifice one of those muscles and you make them slide in such a manner that you close the midline. So this is in a very, very simplest way that I can describe a component separation. And now they have stood the test of time. Since 1990, Ramirez did it, and Yuri Novitsky started doing from 2006. So it has now seen almost more than a decade of surgeries. And we have seen that, yes, they have a very lasting results and a very, very less recurrence rates in the range of around 4-5%, which is acceptable in this big giant hernias.
Wonderful. Dr. Baiju, do you think that you are also getting those kind of subset of patients who needed abdominal wall reconstruction or who needed component separation techniques? Do you think that we were ignoring them, or you were getting it and then you are still offering the old school of IPOM or IPOM plus?
No, we are regularly used to get it before also, but the understanding of component separation is actually fresh to us, and we started doing component separation after the understanding came to our mind. Actually, we are also getting cases with the dorsal domain, cases with the lateral hernias and all, and we submit the patient for component separation if it is indicated.
Wonderful. Dr. Shinde, how do you qualify in your mind that this patient is going to need an laparoscopic or endoscopic component separation, or this patient definitely should go in for open component separation? I will ask about anterior and posterior from Sarfaraz, but how do you decide that this patient is for endoscopic vis-a-vis open technique?
All the hernias which are generally between 6-7 centimeters to about 10 or maybe 11 centimeters. These kind of defects can be managed with a minimally invasive approach, and up to 12 centimeters in a large abdomen in a female patient, right from 6 to 12, we will be able to do them endoscopically, whichever, either endoscopic anterior, endoscopic posterior, ETAP, whatever the approach. But whenever the defects are larger than 11 or 12 centimeters, whenever they are associated with multiply recurrent and meshes in different planes, and especially when these hernias are associated with loss of domain, either gross or even relative loss of domain, because of the size of the patient, because of the rigidity of the abdominal wall, because of multiple hernias, or maybe even the sex, male patients are much more tougher to handle, especially if they have a very strong muscular wall. Then these patients definitely doing endoscopically would not make sense to me. I would go for an open component separation.
But you have been very well trained for laparoscopy. But what do you advise those people who have not been very well trained for IPOM or IPOM plus, and then they have to choose this specialization of AWR? Should they go in back for IPOM and IPOM plus, and then make them proficient in endoscopic techniques, and then switch over to these techniques, or straight away they can jump to AWR?
Well, abdominal wall reconstruction endoscopic techniques are really not very easy. They are difficult even for trained surgeons like all of us. We will all have our own learning curve, although we must have been doing laparoscopy for more than 25 years. But the ETAP approach or the endoscopic approaches are not very easy. So definitely for young surgeons, there would be a learning curve, and they should go in a stepwise fashion. First, I would suggest that every surgeon should master the basic laparoscopic surgery, IPOM plus, and the IPOM repair. Once they are very well trained in the minimally invasive approach of the IPOM plus nature, then they can progress towards the endoscopic approach. And even then, when it comes to an endoscopic approach to a component separation, every surgeon should be well trained in doing it the open way, because unless we are well trained in the open surgery, we will not be able to understand the planes. We might miss out on the planes, and we might produce more harm. So the first principle of our philosophy is do no harm. So it should definitely be stepwise.
Sure. Sarfaraz, what do you want to say about which one is better, anterior component separation or posterior component separation?
Well, I think what everybody would like to hear is that posterior component separation is better. And what I would like to say is that in my practice, based on my experience, I have found so far no difference between the two. I do see the literature is now showing, if we look at the last comparative systematic review, is that the SSO is higher in PCST, SSO is lower in perforator sparing ACST, and also in endoscopic ACST. So SSO is high. However, the recurrence rate is half, let's say 5% in PCST and 10% in ACST. That's what the paper says. That's what the literature supports. There is also literature suggesting that PCST and ACST, the medialization is same. This is what is written in the literature. Now, telling you all of this, I would like to add from our own personal experience. We find that the medialization with anterior component separation technique is higher than posterior component separation technique. And when I say higher, I mean the anterior sheath comes much more easily together with an anterior component separation technique compared to a posterior component separation technique. That's number one experience that we have. Two, we do find this is technically easier. ACST is much more easy to teach any surgeon, even if they're coming from a district background, not having access to many things, they can do this. And they don't have to worry about the neurovascular bundle. They generally don't have to worry about so much of gut injury. The only thing with ACST is if one does not understand the vascular anatomy of the anterior abdominal wall, then surgeons may land up with wound necrosis. And when they land up with wound necrosis, they blame the procedure, not their own knowledge of anatomy. For example, if somebody had a subcostal incision or a groin incision, that patient is not a suitable candidate for an ACST because that flap is going to take away the vessels that are there, that is the rectus perforating vessels, because already the lateral vessels are gone because of the previous incision. This simple understanding may be lacking. Two, one does not identify the perforators when doing the elevation of these flaps. And then also one can lead to wound necrosis. People think that putting in a mesh anteriorly may lead to more wound infections. Well, there is no paper suggesting that. It's just a myth. The earlier, for example, when we talk about ETEP, Reeves Stopa versus IPOM plus, IPOM, we do not understand that IPOM cannot be compared to ETEP-RS. We can compare IPOM plus to ETEP-RS because then the sheets are being closed, the defects are being closed. That's apples and apples, not apple and orange. Similarly, in ACST and PCST, when we did not have a negative pressure wound therapy, I think many of these ACST wounds were managed poorly. The understanding of negative pressure wound therapy has come in the last 1 decade to us, maybe a little more to others. But after having that knowledge, it doesn't matter whether ACST or PCST, whichever wound gets necrosed, or there's an SSO or SSI, we can manage it very well. In fact, it is much easier to manage an SSI after ACST compared to PCST because that mesh explantation or what is happening beneath the mesh cannot be said with confidence despite the CT scan. So ACST has certain advantages. I know I'm swimming against the tide. I am taking the risk of being an obsolete man, but I think that is my personal experience and I think it cannot be written off. And I don't think it will be written off. I just think it will suffer with some bad publicity for a few years and it will be back. It will be back and ACST and PCST will be having their own place. The overlap of PCST is something that cannot be compared with ACST, and that overlap is a distinct advantage. And I think the recurrence rate may be a little better with PCST. But the rest of the things, the technical advantage, the management of the mesh, the chances of injuries, the chances of rectus atrophy, the chances of so many things that can go wrong with PCST, the difficulties of doing that surgery, I think all that is not there in ACST. So whenever we see a huge hernia, mushroom kind of a hernia going up till the linea seminaris, it is ACST in my hands. If it is not going that way, it's PCST. Loss of domain many times will go for ACST in my hands.
Sarfaraz,
so that's my answer.
You have justified my asking you a question to you. Thank you very much.
Thank you, sir.
Good. Jignesh, I have to learn AWR. And should I do ETEP inguinals first and then go in for inguinal ETEP ventral hernias, or I can do it separately and then graduate myself to component separation of any and every angle?
In fact, sir, nice question. So if you ask me, probably I would say that ETEP-RS technically to understand the anatomy would be much easier and you will be doing less harm to the patient. Because the thing is that you are well versed in a big open plane. Doing an ETEP inguinal needs a little bit of trick because the peritoneum is going to be very, very close and sticky to your posterior sheath transversalis fascia area. So I feel that both of them have an individual learning curve. I would probably say that doing in a TEP is more, and then gradually going on to ETEP inguinal with a mentor, not to damage the peritoneum and creating a large space, and then learning of the ETEP RS separately, because ETEP RS is a complete different area. But once we have learned ETEP RS well, the lower part is ETEP inguinal. So it becomes easier if you learn ETEP RS properly. Your ETEP inguinals become much easier, because then you just have to shift your camera to the lowermost port, and then what you see is the ETEP inguinal. So I think both of them, I'll probably train them differently, but I'll make my fellow understand the ETEP RS concept well, so that he can graduate to the ETEP inguinal early.
Sure. Dr. Punjani, I shall ask, yeah, Dr. Shinde, go ahead.
I would second Jignesh, because I am a TAPP man. I love TAPP for last more than 20 years. We've been doing it, and I found doing ETEP RS a different ball game, and I love doing ETEP RSs. And therefore, it is not mandatory that you have to go first for TEP inguinal, then ETEP inguinal, and then do an ETEP RS. In fact, the learning curve for ETEP inguinal could be higher. I fully agree with Jignesh on that.
Dr. Punjani, may I ask you that so much of confusion has been created, precisely confusion has been created by naming in abbreviations, SCOLA, EMILOS, and TAR, and so many such kind of terms are being used. Do you have clear-cut indications for the procedures in your mind, or you will offer some AWR?
The defect, and I don't want to do a too massive a procedure, probably it will again be if this patient is not very obese and if I'm comfortable doing it. Now anything larger than that, of course, I'm going to now switch over to the component separation. These new SCOLA and all are concerned. So that is again the patients whose BMI is not very high, where the defect is a small, and there is usually a divarication associated with it. That is where your SCOLA would probably be required. You can also do an ETEP. So there is certain overlap of this. It depends upon your comfort zones, what you are good at it. So as very initially what Sarfaraz said, you have to also think of a patient, the wound, the defect that is there, and then you decide what you want to do. So these MILOs, EMOLOs, these are all a type of the retrorectal repair done in a different manner. But ultimately it is the same thing. So it depends upon which route is good for you, that you do it.
Sure. Dr. Baiju, yeah, Sarfaraz, go ahead.
I think in the future, we will have something that we are now promoting in the data collaboration. We would be just talking about where have you placed your mesh, onlay, sublay, or intraperitoneal? Have you done this open or laparoscopic? Have you done a CST? That's all there would be when you talk about a procedure. The names would vanish. I think that should make it easy for everyone.
Precisely, Sarfaraz, this was the question which I was going to ask Baiju also. But Baiju, you have a patient of...
Name actually came in because...
Baiju, this is a patient of 2.5 centimeter umbilical hernia with divarication of eye, and she is 33 years old and she has completed her family. So what do you offer?
I will opt of... hello.
Yeah, go ahead, please. Baiju, go ahead.
Can you hear me?
Yeah, we can.
Hear me?
Yeah, we can hear you. The clock is clicking. Dr. Shinde, in such a vast experience of doing AWR, how many complications have you seen or have you heard being tackled, and have you read about AWR complications?
I'm sorry for that. Actually, got disconnected.
Yeah, go ahead. Go ahead first.
For a 2 centimeter defect with the divarication, I definitely go for IPM plus only unless the patient wants for a SCOLA or something. To add to the comment made by Dr. Sarfaraz, that's all the new descriptions about Emalos, Schola, everything is just because came the surgeon who designed it wanted to have a name with some fancy name.
Baiju, just
Means that is fitting.
what are you going to do? Divarication with umbilical hernia of 2.5 centimeter, 33 years old female, and she has completed her family. What is your answer?
IPOM plus.
Dr. Shinde.
If earlier I would have done an IPOM plus with repair of the recti divarication. Today I would offer an ETEP RS because there I can tackle the divarication also very effectively.
Dr. Punjani.
Yeah, I think this is a candidate for Schola to me. 33 is not a very big MI, this thing, BMI, and
So it's going to be ETEP RS in my hands in patients who want their divarication repaired. If they don't want their divarication repaired, and if it is not W2, W3 divarication, I would be happy to just leave it with IPOM plus.
Dr. Jignesh.
Sir, I would do a Schola if the divarication is more than 5 centimeters, a Schola. If it is less than 5 centimeters, then ETEP RS, because more than 5 centimeters, you try to do an ETEP RS, you will burn your fingers. Let me tell you, with the PRS disruption.
Sure.
So let's be very wise in such cases.
Wonderful. Dr. Shinde, I was asking you about the next 6 minutes we'll be spending on complications. So in precise, what complications have you seen, heard, or read of abdominal wall reconstruction, so that our younger colleagues do not make the similar mistakes?
Well, if you talk about having seen, heard, or read, it is every possible complication right from small to devastation. I have personally faced complications of rectus sheath hematoma, which we had to go in and evacuate. In one patient, we had to face a complication of PRS rupture, where we had to do a laparoscopy, manage that patient. And in both these patients, the intervention was necessary. These are not the complications that can be conserved. Most of the times, you have to act early and swiftly. All these complications can be managed endoscopically, but early diagnosis is key to safeguarding the patients. As far as abdominal wall reconstruction surgery complications are concerned, the complications tend to be more devastating, and every possible complication is known. Few of them are the dreaded complications, like the PRS rupture. The posterior rectus sheath rupture is one of the dreaded complications because it presents suddenly. It presents in a devastating way, and the patient is open to an intestinal obstruction with strangulation, and the patient can deteriorate very fast. Otherwise, right from hematoma, hemorrhage in the spaces, wound infections, SSO, mesh infections, even missed enterotomies, because most of these patients will have recurrent hernias. When we take up on abdominal wall reconstructions, they are not going to be simple, straightforward cases. They could be multiply recurrent hernias, and these patients can come with missed enterotomy or a delayed peritonitis because of a give way of a suture, and including medical complications like abdominal compartment leading to a devastating complication and pulmonary embolism.
Sure.
There have been patients who have lost lives also in abdominal wall reconstruction.
Dr. Jignesh, 5 lessons.
Sir, if you, yeah.
The 5 lessons you want that the younger colleagues should learn before going in for AWR.
Lesson number 1, please choose a very good mentor, because that is absolutely, the captain has to be very, very good. Lesson number 2, learn your anatomy, preferably in a cadaver rather than a live surgery, because that always helps you to go around and play with the tissues. Lesson number 3, please watch the surgeries from all the different forums. You can watch it on the social media, you can watch it on live, you can watch it on the webinar. Lesson number 4, which my boss had taught me, was read the complications of the operation first and then read the operative steps, because then you will come to know at which step, if something goes wrong, this complication occurs. So I do this reverse engineering. I always tell my residents, read the complications first, then read the operative steps. It will be very, very easy. And lesson number 5, be friends with wonderful people like you around so that you can learn each day more and more.
Thank you very much for the compliment. Dr. Punjani, how many times have you tackled one patient many times for hernia?
Yes, yes. So now, in fact, I was going to say when Dr. Pramod Shinde said, in fact, I must have seen many more, the largest amount of complications because I've been doing component separation for now more than a decade. But I've seen, the people with one is, in case you tend to infect the component separation patient. I think that is something which is a disaster. This patient will need a multiple, vac dressings. Maybe, after some time you think it's not turning around, so you explant the mesh. So after explantation of the mesh also, the wound will take longer to heal. So they require multiple surgeries. Number two, if these patients have an enterotomy and which you have not diagnosed, now that's something which is very, very devastating, where you will be going late, the patient is in sepsis. You try to bail them out, you may have to do a stoma, and then after a while, again a stoma reversal, and eventually they will definitely get a hernia. So again, a herniaplasty or one of the component separation. So these are multiple things that that I've seen patients undergoing. In fact, I also remember one patient where I had done an IPOM plus in a gynec setup where I was asked to come to operate on a doctor's mother. I said that please let me do it in my setup. He said no, everything is very sterile over here. And I did a mistake of doing that. And unfortunately, the IPOM has got infected. And I had to again go in laparoscopically with a lot of difficulty. We removed the mesh and we left that hernia open, which again got a recurrence. And then again, I had to go in. So, there are some patients where we have gone multiple times with a guilt. But I think this, if you want to venture into such large hernias, this is probably you have to be ready for all this.
Sarfaraz and Shinde and Jignesh and Baiju, just one question. What do you think that robotic surgery is going to have a place in AWR?
If you ask me, yes, because the suturing on the roof is one of the biggest advantage of robotic surgery. And when you do complex cases, I'm talking about the small subset of 5 to 10% patient, I will choose for robotic, not the 90% which I can do with straight sticks or open surgery.
Dr. Sarfaraz?
Yes, so in my hands, if I have to suture the entire abdominal wall, entry abdominal wall in the roof, I would like to have a robot. But if I don't have a robot, I will have to make in 3 more ports lower down to do the upper suturing and upper port for the lower suturing.
Dr. Shinde,
that's the only advantage.
Yes, no?
Well, robotic surgery is going to be very helpful for complex surgery. Definitely.
Sure. Baiju?
Yeah, robotic surgery will be helpful for those surgeons who are not at all exposed to the complexity of laparoscopy before. Probably that will help the surgeons.
Thank you very much. I think we have just 30 seconds left and we would definitely stick on to the time. I must appreciate that I tried to put you some embarrassing questions, some straight questions, but you have answered them so well. And I feel, honestly, as Dr. Jignesh has also pointed out, that we, especially when we gray our hair, then we should carry on remaining the learners rather than become the learneds. The day we become the learneds, I think we are dead. So we should carry on learning. Thank you very much for joining for this webinar on ventral hernia repair. Thanks a lot. God bless you all. Stay safe.
Thank you.
Thank you.
Thank you, Dr. Bhatia. You were an amazing moderator.
Thank you.
You asked illegal questions, but you got away. Thank you very much.
And
Thank you.
Time has been kept.
Sure.
Thank you. Great.
Thank you, sir.
Thanks a lot. Thank you.
Thank you.
Thank you, doctors, for your valuable time. Thank you so much.